Our next presenter is Dr. Jeff Hughes. Jeff is an orthopaedic surgeon at Chatswood, the North Shore Private Hospital. Dr. Hughes is the president of the Australian Elbow and Shoulder Society. He's a regularly invited speaker internationally. He teaches for the Mayo Clinic Elbow course in the US, and also a tutor for the Conrad Moray Elbow Arthroplasty training, which is only 3 of those in the world. So we're delighted to have Dr. Hughes with us tonight, and we're delighted to have him give us some insights into his clinical practice in the use of these novel treatments. Thanks, Dr. Hughes.
Good evening. Can I just confirm that you can see the slides? Okay, I'm going to start now. These are my declarations. Okay, tendinopathy in the upper limb. As we've heard, it's very common, and it's both a general practice issue and a sports medicine issue. The histopathology has been beautifully demonstrated before. One of the problems we have with tendinopathy is that the various bureaucratic instruments do not recognise it as a major impairment issue. And the patients are often the victim of leave it alone and it will get better, despite the clinical reality that many of these patients do not get better over an extended period of time. And often the time frame of resolution, if it does occur, is in fact incompatible with financial and work pressures. And what I'd like to bring your attention to is that there was a little study that was done in the Mayo Clinic where they looked at all their common extensive tendinopathy. And basically what they demonstrated was that if you had lateral epicondylitis and you still had symptoms at 12 to 18 months, there was still at 5 years a chance of 70% of those symptoms still being present. So this is a condition that once you've got it for an extended period of time, it is maybe a very long period of time and incompatible with certain occupations. So if you look at the people who get common extensive tendinopathy, it's manual workers, especially the workers' comp patient, and they are straight away a more difficult patient. There's the office, healthcare, and manual workers. So the spectrum is broad, and it results in a huge, significant socioeconomic benefit problem. If you look at the potential problems, if you go back 200 or 300 years, the French used to treat it by frappage, and that was basically hitting the elbow with a mallet. So there was a level of trauma that was associated with resolution. There was steroid injections, and with the data is replete with demonstrations of short-term benefit, but the long-term exacerbation of problems is now being recognised. Physiotherapy is where there is some controversy. The physios will often commence eccentric exercises. And in my opinion, I actually see an exacerbation of problems rather than an improvement, whereas in the lower limb, we may see benefits from this. We often see tennis elbow splints, wrist splints, proline therapy, extracorporeal shockwave therapy, various forms of ultrasound ablation, dry needling, PRP, or combinations thereof. And then there's the percutaneous tenotomy procedures at the elbow itself, but also in terms of proximal EDC tenotomies being performed. And then there's the arthroscopic and open debridement procedures. What I'm going to concentrate on are the biologically active cells, and the one I'm going to concentrate on tonight is ATI. So I suppose the first thing that needs to be said is this is not stem cell therapy. This is a mature tenocyte injection. This is the case that sort of crystallized my experience with this treatment. This is a 55-year-old female CAD worker. So she was using mouse in both hands, and she reported that she presented to me with right, worse and left bilateral elbow pain in August 2009. And it got to the point where she was in constant pain, even at rest, by 2010. She was workers' comp, but self-employed, so it was her own business. She had all the incentives to keep the business going. and she had a number of injections. She had a surgical procedure done. She had a failed PRP injection. In fact, the insurance company confessed on a phone call to me that they were engineering her run-out time in treatment time. That is, they'd given up on her. So we actually started an ATI on her, and in July 2013 we injected tenocytes into her right elbow, and this is her pain scores at various time points, and you can see that there is an early benefit seen in this lady at rest, and at 3 months there is an embedded functional improvement, and there is improvement which has been maintained over 2 to 5 years. And the first thing I need to say here, there are very few surgical studies which go past 12 months, let alone 2 years, and none at 5 years that I'm aware of. So this type of sustained benefit is very important. These are her studies, and you can actually see the sutures where they repaired her ligament back. And these are her initial studies, which shows an extensive interstitial tendinopathy, no defect. And at 1 year, we can actually see the formation of more normal tendon. And this is unusual. This doesn't happen with treatments such as PRP. And this is her 5-year ATI result. And essentially, she has a normal common extensor origin. And she maintains her result at this stage. So what is it? And you've seen this slide before. It's essentially treating the late stages of tendinopathy where we have a depletion of functional tenocytes. So selection of patients is very important. So while patients have normal tenocytes and the ability of those tenocytes to do, the patient's own tenocytes to do what needs to be done, you don't need ATI. But the later stages is where they need the tenocyte repopulation. The original studies talked about tendon biopsies of the patella, but I now use either FCR and palmaris longus because I find it better tolerated by the patients. And you've seen this study before, and what is important about this is that this is a 4 to 5 year study. And if you look at studies, most of them are at 12 months, and it's this sustained response to treatment, which is very important. And this is very important in the setting of an occupational disease. So in my patients, all patients need to have only partial thickness, not full thickness tears. They need to have more than 6 months, which produces an embedded tenocyte issue. And they all need to have failed the simple measures. And essentially, most of these patients, in most surgical practice at least, would be therefore those who would normally come to surgery. And in my practice, I have probably reduced my surgical intervention by about 80 to 90%. I try to avoid previous elbow surgery. I try to limit the steroid injections to less, not in the recent 3 months, and unrelated trauma. In the person who has an acute trauma with a total disruption, in my hands, they get a surgical repair. This rehabilitation program following ATI was developed in Western Australia and remains the basis of how we manage these patients. And that can be easily downloaded from the Orthocell website. In the original study, the original patients were all non-workers' comp patients. So those studies out to 4.5 years were all non-workers' comp. But really, in the real world, we are looking after the majority of patients are actually workers' comp patients. And those workers' comp patients do well. We actually see, with a long follow-up, an excellent improvement in symptoms. And you've seen this slide before. And what is important is this slide is a 5-year study, but it still takes, with this treatment, at least 3 months. This is not a quick fix. This is a treatment which is for someone who is in for the long haul and wants an elbow that they can use for more than 1 year. And this has been validated on MRI outcomes. And from my point of view, this is the only treatment that in fact results in a normal MRI. And these are some of the validation MRIs which can be seen in this paper. So in my opinion, it results in clinical outcomes with improved function and restoration of the patient to their previous work activity. But to balance this against when I choose an ATI or surgical debridement, we have to decide what is the gold standard. Now, in the old days, the gold standard was a surgical debridement, but it's important to look at what they called a cure. Most of those surgical patients did not talk about a cure. They talked about a significant improvement, and significant improvement could be as low as 50% improvement in pain. If you actually ask the patient, I did an operation, did it cure you? Did you have a no elbow symptoms? Did you have unrestricted use? And most patients in my practice, that answer is 70% in the setting of surgery. But these surgeries can have CRPS, they can have fistulae, they can have instability, and the rehabilitation is quite long. If you look at the early stages of epicondylitis, most of these patients can be managed non-operatively and without ATI. So the early stages of epicondylitis are not treated with ATI. It is the patients moving from 3 to 6 to 9 to 12 months that we start to see the use of ATI. And then these other treatments start coming into play, such as PRP, surgical debridement, ultrasound ablation. And all those have been demonstrated to have a degree of efficacy, none of them out to 5 years. So for me, the indications for Orthocell are an MRI where we have clear definition of tendinopathy. And this helps rule out the clinical decision, is this patient's pain neuropathic or is it well-localized mechanical tendinopathy? They have to have well-localized tenderness and tendon provocation signs, and a failure of symptoms to progress despite a level of acceptable patient needs. So we looked at our patients specifically in terms of work-related or workers' comp patients. And essentially, we looked at patients who had a lesion in continuity, not a big defect. Lamination pathology was not excluded, and we also had to have well-localized clinical signs in terms of ECRB provocation signs. And in addition, in these patients, many of them have had previous surgery, and we did not exclude these. So this is a true representative group of workers' comp patients. The one exclusion that was important was we excluded steroid injections. If the patient had evidence of posterolateral instability, they went straight to reconstruction and surgical repair. I need to go back. And so in these patients, this was a joint study with in Sydney and Perth with Dr. O'Brien. And we put together 24 patients. And what was important was only 60% of these were manual. There's still a high proportion of office-based or dexterity-based patients. And many of these patients had had multiple treatments. So more than a third had 3 or 4 treatments. And look at the length of time that they'd had symptoms. These are patients well out past 12 months. If we look at the type of treatments, there was a broad spectrum and it included both non-operative and operative patients. Now, if we look at pain at 3 to 6 months, the pain was reduced to 90% at rest and 54% of patients reported reduced with activities. What is important also with this activity profile is that if you actually ask them, if you got pain with activities, how long it actually took you to recover. Most of these would say within hours or a day, whereas in their pre-intervention state, it would take them days or weeks to recover. So that their recovery phase was also shortened, but that was much harder to quantify. Of these patients, 80% returned to some form of work and 50% actually returned to their previous work. And that's a significant number. That's a number which is generally not achievable in the typical chronic, more than 12 months surgical intervention patient. And so return to full capacity was seen in 12 patients out of 24. If you look at the ATI dash scores, these are the pre-ATI. Now, in our patients with work-related injury, we are not as good as the non-workers' comp patients. This is the 4.5-year study. But we are still within range of being significantly improved and much better than the preoperative status. So essentially, the evaluation of the medical history relevant to the treatment of the common extensor hernia and capacity to return to work is significantly improved with ATI. And in my practice, if there isn't a major disruption in the common extensor origin mechanism, ATI is my go-to intervention. And I think because it is minimally invasive, it's less likely to exacerbate any underlying neuropathic issues. So in summary, future studies will need to be done on these patients, but at the moment, they are very positive in our hands at this point in time, having used them for a number of years. I'd like to acknowledge all these authors in terms of the science that's been presented tonight, and also the rehabilitation and the ongoing research that's being generated by Orthocell. Thank you.